Good afternoon. I'm Joe Mills from the Baylor College of Medicine. It's an honor to be here at the 50th anniversary of Frank Veith's meeting in New York. And today we have three panelists to discuss a complex and controversial issue. And that is the possible or potential overuse of interventions, especially in below the knee arteries, especially in the outpatient space, and especially involving devices such as atherectomy. So I have to my left Dr. DeRobertis, Dr. Hicks, and Dr. Jane. And I'm going to probably just ask them each to answer a couple questions up front. Is there a problem with overuse? If so, how do we address it? And then what evidence is there to address the issue of which devices we should be using for what indications and in what setting? So Brian, if you could start.
Sure. So I also would like to congratulate Frank on his 50th anniversary of the meeting. It's really great to be here and participating in this. I do think there's always a potential for overuse of procedures. You know, we try to strike a balance between doing a proactive intervention to help a patient prevent a bad outcome and not overdoing it with some of our interventions. So there's always a potential, and that potential exists in the hospital, in the outpatient space, and it exists across all different devices that we have. And I think that it's important to know that most physicians choose the right device for a specific patient and for the specific problem they're dealing with. And that can include use of atherectomy, which is of course something that has been talked about quite a bit. It can include stents, other devices, and I think that we need to recognize that while overuse can occur, not getting appropriately treated is also a problem. And patients who have their care delayed out of concern of some of these issues, I think that's going to potentially impact patients negatively as well.
Huge congratulations to Dr. Veith, and big thank you for the opportunity to be part of the panel. I agree that overuse is maybe a problem. I think I feel more strongly that it is slightly more problematic perhaps than Dr. DeRobertis does. I think there's a fine line. It's patients with claudication where I think the overuse is really happening. I totally agree that patients with chronic limb-threatening ischemia, at the threat of losing their limb, they need to get the care that they need, and you need to do what you need to do to save that leg. In the space of claudication, however, I think that there's a lot more gray zone, and that's where I feel like we see a lot more overuse and potentially misuse patterns. Tibial interventions below the knee, for example, for patients with claudication, really should not be done. Multiple society guidelines agree with this. The new European guidelines that came out last week say we shouldn't be doing this, and yet in somewhere between 20 and 30% of cases, we're still doing it. So I think it's a blatant pattern of overuse, and we have a lot of work to do in that space. In terms of the types of devices being used, there's been a lot of discussion around the use of atherectomy. I do think that there's benefits of atherectomy in certain disease processes in certain patients, regardless of their indication for revascularization, but I don't think that atherectomy use in 100% of patients is ever the right answer. And so I think there's certainly some abuse and overuse patterns in that space as well.
Yeah, Krishna Jain. So congratulations to Dr. Veith, of course. I did a case with him actually almost 50 years ago when I was a resident. He came from Montefiore to New Jersey, and I did a case with him. So our relationship goes that back. Now, this is a very important issue we are talking about right now, overuse or abuse. Ethically, nobody ever should do a case that is not necessary, because patients come to us with the total faith in us, and we should do nothing that is unnecessary. Having said that, a lot of discussion revolving atherectomy and below the knee use, etc., is based on data which is flawed, because the data comes from Medicare data, which is not a very comprehensive data set. There's been now articles also from VQI, and even that data is not as comprehensive as one would like to be. There are no really randomized studies comparing one study versus like atherectomy versus balloon angioplasty stent alone, etc. So the data that we are making decisions on is flawed, and many times the OBLs and the ASC gets trapped into that, because a lot of this work is getting done on an outpatient basis. Yes, there may have been some abuse, it is possible, but at this point I can guarantee this is not because of financial reasons, because if you look at the atherectomy payment from CMS to OBLs, it has gone down by 25% between 2018 and 2024. So actually at this point it is more profitable to do, if you look at the overall profit margin, I shouldn't say profitable, for doing a case in OBL, the angioplasty stent versus angioplasty atherectomy, probably there's more profit margin just doing an angioplasty stent versus angioplasty and atherectomy. So I think that this is a very complex issue. The data is not there, and a lot of data that has been evaluated is not granular enough to make decisions on.
I think it's a complex issue. So the New York Times article brought this all to a head recently, and part of the good thing was to try to educate patients about what to look for and what they might expect to treat as treatment. But the bad part of some of it was they lumped patients together that had chronic limb-threatening ischemia with those who had claudication. And one of our fears, and we actually put this in our Society for Vascular Surgery response, is you don't want patients to be afraid to come in to get care that they need, especially for CLTI, because they're afraid they're going to get a procedure they don't need. That's a different class of patients, though, than patients who have atypical leg pain or claudication, many of whom don't need an intervention or probably shouldn't even have an intervention for a long time. So I think we need to address this issue because there's a subset. It's probably pretty small, and the data that I've seen pretty much agrees. It's less than 20% of people that are doing procedures. But that's going to hurt all of us because it's going to cut reimbursements for the bulk of people who are doing the right thing. So as a society and as a group of people taking care of these patients, we have to come up with some way to allow some regulation in the space without being over-regulated to the point where you can't do anything for a patient that they need and have to get approval for every step of the process, because none of us wants that. I mean, in the end, a conscientious physician who's well-trained, who's in front of the patient, is going to make the best decision, right? So how do we rein in the extremes? Because I think all the panelists would agree, we practice in different settings, but there is a small subset that hurts all of us. So how do we educate the population, deal with reimbursement issues, and control that without having the government do it for us, I guess is the big question.
Well, I certainly don't have an answer for that, but I will say I share your concern about the New York Times article. I think nowhere in that article did it stress to patients who are reading that the importance of revascularization for CLTI. And I personally, within 1 week of that article, had 2 or 3 patients actually who were concerned about proceeding with an intervention who had limb-threatening problems. And so I think on balance, that article probably did more harm than good, even though it did point out a number of real concerning issues and trends. But I do think this is, again, it's a complex problem. I, for example, don't agree that all patients with claudication I don't agree that no patient with claudication should have tibial interventions. There are certainly very specific situations where tibial intervention is appropriate, but on average, I think, yes, claudicants with tibial interventions, the amount of disparity we've seen between atherectomy and the OBL versus the hospital, these are issues that need to be addressed. How do we fix this? I think that's much more challenging. But I would say that all parties play a role in causing the problem or perpetuating the problem. I think our societies haven't done enough to sort of establish clear guidelines, despite the fact that we all work on guidelines. We don't all do it in a specialty independent or specialty agnostic way. I think that reimbursement bodies have played a role in incentivizing some bad behavior, and I think it's going to take a team effort of all of these different groups to change the issue.
Yeah, I think, a lot of the heart of the issue, I think, comes from the reimbursement processes around interventions for claudication or CLTI. We're paid as in a fee-for-service system, and so you only make money if you do procedures, and you make more money if you do more procedures on different patients. So I think for the claudication issue specifically, moving to an episode-based cost of care for Medicare, where you're actually paid holistically to take care of that patient, be it with or without a procedure, will be much more beneficial to the patient. You're going to lose out on the long run unless CMS restructures their payment schema, though, and that's going to make some of the businesses totally unsustainable. So it's not an easy fix, certainly. It's going to take a lot of work, but I think that's probably where we're headed.
Yeah, a couple of things. Number one, in the New York article, it's a misrepresentation, actually, because all we talk about in that is that the doctor got paid $10,000 or $11,000, whatever the number may be, when he did in the OBL, while in the hospital he would have made $560 or whatever the reimbursement is in that region. But one thing we do not talk about that, including the journal articles, they always miss what the hospital would have gotten paid. If you combine what the hospital would have gotten paid plus the professional component, it is always higher than what is paid in the OBL or an ASC. And because OBL, ASC running their own expenses just like a hospital. So it's misrepresentation in articles like that, which confuses the patients, because they think the doctor doing in the office actually is making $10,000, which is very far from true. The second thing is the claudication part. Some people will need intervention because the best medical management, which includes exercise, which includes all the other parameters, most of the country does not have access to supervised exercise. They just don't. I mean, 33% of the American population does not have a single vascular surgeon in their community. Yeah, so some of the claudicators will need intervention. Talking about taking care of tibial arteries when we are taking care of a claudicator, in our practice, for example, if we did an angioplasty or something for whatever procedure for SFA, and they had also severe stenosis in one of the tibial arteries, and that was the only artery left, we would probably dilate it or do whatever needs to be done for that particular artery. But if you look at the Medicare data, it will show up as if we're doing tibial intervention for claudication while we actually was doing the SFA intervention, but the data is not granular enough to separate those out. And so it makes very complex situation taking care of patients, because when you are there, you see a severe stenosis, we tend to take care of it.
Yeah, I think unfortunately our system is based on procedures, and that's what we get paid for. And so whenever there's a realignment of a payment process, everybody, it's not just OBLs, hospitals do the same thing. If you try to develop a limb salvage program in your hospital and get resources for it, those resources have to come from transplant surgery or bariatric surgery or other entities which might make more money. And guess what? You probably will be at the end of the line. So the financial issues affect everything. I think there ought to probably be a shift towards care of the patient. So for example, if you had a CLTI patient with complex multi-level disease, you get paid regardless of what you do for them if you provide complete care. So are they on all their risk factors? If you did endo, were they a high Wi-Fi, high glass classification, you should probably get paid more because they're going to be more difficult. They're going to require more readmissions, more procedures. And right now we don't get paid that way. If I treat an SFA and a claudicant, it's an easier lesion to treat. I get paid the same as if it's a difficult recanalization in a CLTI patient where I may decide to wait on the tibials because I'm not quite sure and I'll go back later. So that's a redo, so you get penalized for that if you don't. So we don't get paid by care of patients, we get paid by procedures. So as long as the system is driven that way, I don't see anything changing it, because all our healthcare system, whether it's outpatient or inpatient, has to at least break even to survive, right? So you're going to look for opportunities to not lose money, right? It's just that's the way the system is. I think most of us are trying to do the right thing, and most of us. I'd like Caitlin to go through her data because I think she's been misinterpreted. But if you look at some of the data, there's certain things that stand out, and it's a very small set. If you set the bar at a really low bar for what constitutes potential overuse of some technology, it's a pretty small number of people that are on that part of the curve. And so she's not indicting most practitioners, is my take on it from what I read. So if you could cover that.
Yeah, I've looked at practice patterns across a variety of sort of different metrics, if you will, and there's sort of different variation as you go about it. But the bottom line is that it's a relatively small proportion of the number of people practicing PAD procedures in general. It also represents all types of specialties, so cardiologists, IR, vascular surgery. It's a small group of people, so we're not indicting everybody, but it's a small group of people that do a lot of procedures, so it results in a lot of healthcare dollars and a lot of patients at risk. And so I think if we can sort of just tread that fine line where we recognize abuse and overuse, but also recognize that there's variations in care patterns by different physicians and by sites of service, which is okay, that's really where we sort of need to land.
Just to drive home the reimbursement point, so this is related in a way. So the renal denervation for hypertension apparatus was just approved. So the mean blood pressure drop, systolic, was 5 millimeters of mercury. And for that's now been approved to treat hypertension. And yesterday or today, a big article just came out, a large group of patients with or without hypertension, with or not on antihypertensives or on antihypertensives. If they drop their salt intake by one teaspoon a day, so 1 teaspoon, it dropped their systolic blood pressure 5 to 6 millimeters of mercury, and that affected every patient group, whether they were on meds or not. So now we've approved a treatment that's going to be done, and people will do it in good conscience, but are they actually going to make sure the patients are medicated correctly first, cut their salt intake before they get the procedure? Probably not, right? So that's the system where what you reimburse is what you get, and I think that's where we are. And until we change that system, it's not going to change. I hate to be pessimistic, but that's my take.
Yeah. No, I don't disagree. I do think our reimbursement models, to some degree, driving some of the issues and problems we have. And I think that I guess the best we can do is look holistically at the patient, like you mentioned. And for those of us in surgical specialties, we've had the advantage that we've acted as primary care docs for a lot of these patients. We deal with the wound care, the foot surgery they need, and the revascularization. So I think we have an advantage in that way. But I would stress that I don't think that gives us a better position in deciding some of these procedures and which procedures are most appropriate. I think we have to recognize that all specialties now participate in this, and all specialties need an equal seat at the table in discussing some of these things. And so what I would hope is our societies work together to develop guidelines and framework and adherence to those guidelines in a specialty agnostic way, because I think that's one of the issues that's come up as a result of this that has been problematic and not helpful. So.
Yeah, I just want to say, I think we're all saying the same things, in that, the ultimate goal is to provide the right care to the patients. And so that involves medical management, it involves operative decision making, and then in the operating room, it involves, or the cath lab, it involves making the right decisions about what you're going to do for the person. And as long as those are decisions you're making in good conscience, then I think, you're fine. There's this very small subset of people who appear not to maybe be doing that.
Yeah, a couple of the things I would suggest is that the endovascular care is provided by three specialties primarily: vascular surgeons, intervention cardiologists, and intervention radiologists. The societies that deal with them need to come up with the guidelines which are similar, so that they have similar training and they're using the similar guidelines. When the guidelines are different, they practice differently. Number two, when there is a rogue physician, and when people go to societies to name a person who's doing unnecessary care, the societies don't have the mechanism to discipline these people. And I agree with you that there are a certain number of people who do unnecessary procedures. This is given. But there's no mechanism within the medical system to take care of these people, including medical boards, state medical boards that have failed on that. So we need to develop some mechanism. How do we make sure that if they're rogue physician, how we take care of them?
I think to close, the message probably is that we need to figure out a way to deal with the small group of people that are extending things beyond their reach, what they should be doing. But the vast majority of people are trying to do the right thing, and we don't want patients to be afraid to see a provider when they really need care. So I would caution patients, though, if they get a bad feeling, if they think either they're being offered too much too soon or not enough, get a second opinion. Get a second opinion from a different specialist. So one of the things I think that's pushed vascular surgery is we had to learn to be highly competent at endo to survive. So that gives us a distinct advantage because we have open and endo options and hybrid options, but we wouldn't have probably gotten there had we not been pushed by other specialties. So we can't also ignore other specialties that do a lot of endo and do it very well. There's some subsets of cardiologists and interventional radiologists that do superb jobs with many things vascular. So I think for patients, don't be afraid to come in if you have a problem. If you feel like you're getting put into something too quickly and it seems like it's too fast, like a car salesman, walk away, find another dealer, get another opinion. And I personally am never offended if someone asks for another opinion or they ask why I'm offering X instead of Y. I will sit down with them and tell them what I think the consequences of each of those decisions are. And I think that patients should be encouraged to do that. And so don't feel like you have to make a decision that day. For most things, there is time. Even for CLTI, there's a little bit of time for most patients. But for patients especially, they should be educated. And many societies are trying to do that by providing documents that patients can understand. But get another opinion. I think that's always valuable.
I think I like when my patients get second opinions, and I'm happy to give a second opinion because, if you're giving the right opinion, a conscience-based decision or opinion, it should not matter if that patient gets 3-4 opinions. So and I agree, rushing into a procedure is almost never necessary.
No, I think it's a great summary, and I appreciate everybody's sort of discussion around the topic.